gastrointestinal stromal tumors. So today, my name is Hans. I'm an upper GI surgeon from HSA-JB. I'm one of the panelists. With me together, we also have Prof. Lau Peng Chung, who's an upper GI and bariatric surgeon in Pantai, KL. And he's also a visiting consultant in Malaysia, University Malaya Medical Center, where he was actually formerly the head of unit of the upper GI unit back there. Together also, we are very happy to have my old boss, Mr. Ahmad Sudirman, who is an upper GI surgeon from KPJ Kajang, who will be with us today. So, few housekeeping announcements. As you all probably realize, this session is being recorded, and there will be elements of replay on YouTube. Your outgoing audio will be muted. So if you do have questions and you want to participate, please engage us via the chat box, or better still, the Q&A. You'll notice it's actually there on your screen. So as you probably realize, this is an event organized by the Malaysian Upper GI Surgical Society, whereby we're trying to disseminate information, create awareness, and of course, create training opportunities above all else, with the intention of updating everyone as to what are our thoughts, professional opinions, and also what is the latest evidence. So we encourage you to engage us, especially if you find there's discrepancies or disagreements. So other than that, I would like to remind you nice people that many questions have been coming about as to why are we going the malignant pathway this time. That's because the earlier webinar series, which you can see on the Malaysian Upper GI Surgical Society YouTube channel, we actually touched a lot on the benign pathologies actually. So feel free to visit the website, look at the videos there, and pretty modest reviews. If there are any questions, again, you can engage us. We're more than happy to answer your questions. We also encourage you to look out for updates for upcoming events and perhaps training opportunities with regards to endoscopy, cadaveric, and laparoscopic workshops. We'll be putting it up on our Facebook page. So hang on a bit. Without any further ado, it actually gives me great pleasure to introduce our first speaker for today. Dr. Teo Yin Keong is a consultant oncologist practicing in Gleneagles, Medini, Johor Bahru. His expertise is actually not just clinical oncology, but also radiotherapy. And he has served in many institutions in the Klang Valley, such as UKM, IKN, and of course, HKL. He was also the lead consultant in HSI, where I met him, and I really did enjoy working with him for those 2 years, whereby he really showed how we could actually expand our services, and I'm quite indebted to him. He will be talking to us today about targeted therapies and immunotherapy in upper GI cancers. And without any further ado, I'd like to welcome Dr. Teo. The screen is yours.
Okay, so thanks, Ms. Han. Yep. Then without further ado, because I have only 20 minutes to go through such a big topic targeted at immunotherapy in upper GI cancers, so I try to make it as simple as possible for surgeons. Okay, and yep. Few words about introduction. Among all the GI cancers, right? Upper GI cancers are actually one of the most malignant one compared to the lower GI. Okay, and the gastric and esophageal cancers remain a major cause of worldwide mortality and morbidity in the whole GI cancers. And surgery, chemotherapy, and radiotherapy, they are the main treatment approach, especially in the early stage. And however, despite incredible progress in understanding the tumor biology, only a few targeted treatments options have proved to have effective measure in prolonging the patient's survival. And adjuvant treatment is largely interchangeable in between these carcinomas. I mean, whether it's esophageal or gastric, and numerous potential molecular targets have been discovered, and that's why we have targeted and immunotherapy. Nowadays, we are moving towards targeted immunotherapies. Later, I will talk about how we utilize these targeted immunotherapies in the managing esophageal and gastric cancers. You will realize that we are actually moving away from from using the cytotoxic chemotherapy. Okay. Next, a lot of surgeons would have asked me this question: Teo, actually, what is targeted therapy? When my trainee asked me what is targeted therapy, how am I going to answer this question in a very simplified way to my patients or to my trainees? So, targeted therapy, also known as molecular targeted therapy, okay, it is one of the major modalities of medical treatments for cancers. Others are such as hormonal therapy and cytotoxic chemotherapy. These three are the main treatment for the pharmacotherapy for the cancers. It is a main treatment for cancer treatment nowadays. And what does it do? It does, okay, it is acting as a form of molecular medicine, and it blocks the growth of the cancer cells by interfering with specific targeted molecules needed for carcinogenesis and tumor growth. In other words, they don't kill cancer cells. Okay, they don't kill the cells like the cytotoxic chemotherapy, but they interfere with the growth. So rather than killing the patient, killing the tumor cells, they interfere with the growth. So in other words, means the overall adverse effect that can be incurred by all these targeted therapies, they are significantly reduced. Okay, and some of the targeted therapies nowadays are known as immunotherapy. So for the understanding of audience, all the immunotherapies at this moment in our current era, they are all some form of targeted therapies, but not all targeted therapies, they are immunotherapies. It's just like all proton sagas are CARs, but not all CARs are proton sagas. Okay. And then many targeted therapies available nowadays for various cancers, like for lungs, colorectal, hair, neck, breast, melanoma, pancreas, prostate, and so on. And here we need to see one thing. Why we call it as targeted therapy? Because there is some biomarkers. By identifying the biomarkers, the cells, the molecules can be attached to the targets and start the effects after the targets. And mostly, at this moment, I would say that most of the targeted therapies, including the immunotherapies, are designed and effective towards the stage 4 diseases. That's why you hardly see any stage 1, 2, or 3 cancers, regardless of the size of the tumors, are using targeted therapies. Although we do have some exceptional cases, and nowadays that in some of the stage 2 or 3 lung cancers, we started to use immunotherapies or TKIs, but that is one of the rare conditions. In other words, means in most of the cancers, when we talk about targeted therapies and immunotherapy, most likely we are talking about the stage 4. Yep. So for upper GI per se, the main targeted therapies that we nowadays we usually employ is number 1, trastuzumab, which is targeting towards the HER2/3+ or ERBB2 amplification by FISH, or second drug, pembrolizumab, which is targeting the PD-L1, or ramucirumab targeting the VEGF, or tyrosine kinase inhibitors for GIST, like for metastatic GIST, we have first line Imatinib, second line sunitinib, third line regorafenib, or for adjuvant high-risk GIST, you can have adjuvant 2 years of Imatinib. So how we actually utilize all these targeted immunotherapies in esophageal and gastric cancers? Here I split the talk into 2 parts. One is for the first line setting, and for second part will be for the second line setting. In the first line setting, you will realize that there are a lot of preparation needed to be done before we actually can start the treatment. And then the first line setting treatment for all the esophageal and gastric cancer nowadays are, I would say that 90% are targeted therapies. No longer use cytotoxic chemotherapies. So what are the approach to the initial systemic treatment for advanced esophageal or gastric cancers? First, when we receive the patient, we need to look at the histology, the HER2 status, the PD-L1 status, the MMR and MSI status. Although in our setting, we may not be able to get the answers for all these, but we will try in ideal situation. These are the things that we will use to decide what are the modality of treatment that we can give. Then after that, we will look at whether this is adenocarcinoma or this is squamous cell carcinoma. If it's squamous cell carcinoma, we'll go for pembrolizumab or nivolumab plus chemotherapy. The answers you can further read under the keynote 590 or checkmate 5648. Whenever you see any keynotes, that means they're talking about pembrolizumab, and whenever you look at the checkmate, right, they are nivolumab. And here I'm not going to talk further about how to compare whether pembro is better or nivolumab is better, because by default, they don't have a head-to-head comparison. Each one will say that they are better, okay? But when you look at these two trials in detail, you will realize that they do have selection bias, what I mean. Yeah, okay? So just now we were talking about squamous cell carcinomas for first line. So what if it's adenocarcinoma? Once we know that the patient is having an adenocarcinoma of, let's say, gastric cancers, next thing we need to know that whether it's HER2 positive or not. Here I specifically put down whether patient is fit for trastuzumab or not. Okay, because a lot of people may misunderstand that, oh, patient got HER2 positive, that means most likely patient will be benefited from the trastuzumab. This is not actually right in our real life situation, because trastuzumab inevitably will somehow cause the ejection fraction to reduce at least 2 to 5% minimum. So throughout the whole session, we need to make sure that patient do have a sufficient enough of a cardiac function to actually run the trastuzumab. That's why we nowadays, most of the international forum, we like to add in this word that whoever's suitable for trastuzumab who are HER2 positive, we always want to make sure that patient is fit for trastuzumab. That means if the patient by default already having some cardiac failures or ischemic heart disease with a poor ejection fraction, most likely HER2 treatment is no longer suitable for them. Okay, and so we will go to the next step. Once the HER2 is positive and patient is fit for trastuzumab, no doubt we will go for trastuzumab. Trastuzumab is a TKI. It is a targeted therapy. They are not immunotherapies, but by adding in the pembrolizumab together with the cytotoxic triplet, this combination we can see under the Keynote 811. Usually the chemo they use is Xelox or Cis-5FU. Okay. Then how about those who are not fit to, I mean, they are HER2 positive, but they're not fit for chemo, they are not fit for trastuzumab, or they are HER2 negative. So what we can do next step is we have to look at the MMR or MSI. Here a lot of I used to have a surgical MO come to me and say, hey, Dr. Teo, what is actually mean by MMR and MSI? It looks very confusing. Here I briefly listed down what is the meaning of MMR. When you look at DMMR or MSI high, they are actually the same thing. Or when you look at the PMMR and MSI low, they are actually the same thing. So it depends on the literature whether they want to quote DMMR or MSI high, they are actually the same thing. Okay. So when they are MSI high, this one can be checked from a tissue molecule. Okay, from a biopsy sample. So when the MSI is high, next one what we can do is nivolumab or pembrolizumab plus oxaliplatin containing chemo. Same thing here. Nivolumab will say that they're better than pembro. Pembro will say that they're better than nivolumab. Here we are not going to discuss which one is better. Okay. Anyhow, they are targeting the same molecule. So in other words, means in future, whenever you see any drug, any condition that pembro can be used, most of the time, nivolumab can work as well. Okay. Next, how about when the MSI is not high, the mean is low, then we need to look at whether it's the PD-L1 overexpression is high or not. Okay, here we need to look at the combined positive score. Here, we split the group into 3 groups. If the combined positive score is 0 to 4, 5 to 9, or 9 and above, we can see that when the CPS is for 4 or below, we usually go for cytotoxic chemotherapy only because the effectiveness of adding the pembrolizumab is questionable. But whereas it's 5 to 9, we can actually add in nivolumab because nivolumab don't actually go according to the CPS score. But once the CPS is 9 or above, we can actually use pembro plus the oxaliplatin containing chemotherapy. Here, I want to add in 2 slides here to let you understand that understand better what is the role of adding the chemotherapy into the cytotoxic chemo. Okay, role of adding immunotherapy into the cytotoxic. Here we can see that if you are CPS 1, that means you are low positive. You can see the pembro effective period, or over median overall survival is about 10.6. Okay, not far different from the chemotherapy. But once they are CPS score more than 10, they can actually hit here. You can see the difference now. Okay, but people will say that is there on top of adding the additional survival benefit, right? What other things that adding immunotherapy into the chemo can help? It can also increase the objective response rate. In cancer therapies, we are not only looking at the progression-free survival, overall survival, we also look at the objective response rate, because we believe that no matter how effective is a treatment, we need to know that what is the percentage that the patient can respond first. Because we do see that sometimes some treatment can be very fantastic, their result can be very good, but their response rate are not great. That means out of 10 patients, out of 100 patients on this drug, maybe just about 30 or 40% patient can have these effects. Whereas go to the second option, they may not be as good as the first option, but they can have hit the objective response rate of 80 or 90%, right? That means we most of the time we will choose this second option rather than the first option. Okay, after the first line, then we go to the second line. Second line, that means after the first line, after we try the cytotoxic chemo or we try the immunotherapy. So usually when I see any patient that after failure of first line, there are three things that we need to go through. First, number one, we need to see the ECOG performance status. If it's between 2 to 4, usually we don't encourage patient to go for further intensive treatment. Or patient is having underlying poorly controlled comorbidities. This is also one of the negative factors. Or patient opted for no therapy. So whichever these three criteria are positive, usually we have no more further treatment. We discuss with the patient for regarding the best supportive care. But anyway, if the patient are not falls under these three categories, that means we need to discuss further that what we can do. And this will depend on whether patient had a prior immunotherapy or no prior immunotherapy. If patient got no prior immunotherapy and they falls into MSI high or tumor mutation burden is high or CPS more than 9, usually we will try for single agent pembro or nivolumab as a second line. Anyway, if patient got no such mutation status are detected, we will usually reassess a histology and treat accordingly. Let's say like if patient is a squamous cell carcinoma, we go for the cis-5 or if it's like an adenocarcinoma, then we will go for the anthracycline based or taxane based, or even we may try oxaliplatin based on doublet. Yeah. Next, we will see second line. If patient had immunotherapy before, what we can do next? Okay. Second line, if patient is fit for the next line of treatment, we reassess the histology. Here we further split into whether patient is adeno-CA or SCC. If the patient is SCC, after we discuss about all the tumor condition, the prognosis and stage, and patient insists to proceed further and agree to proceed, we'll see that what kind of treatment the patient want. If the patient want more intensive type or less intensive type. If the patient agree to go for more intensive type, we can go for the doublet or triplet of cytotoxic chemotherapy like FOLFOX, FOLFIRI, or even we can try ECF, the triplets. And this is for SCC. For the less intensive type, if a patient is still willing to go for the less intensive chemotherapy, we can go for weekly taxanes, like paclitaxels, or weekly irinotecan. After failure of this line, usually we have no more effective treatment, and most of the time patient will go for the best supportive care. Occasionally, we may still find some of the patients who are still fit and still relatively okay to go for the next line. Then we will discuss for them to see whether they want to go for trial of immunotherapy for whichever drug they have not yet tried before. Let's say, for example, like they have tried pembrolizumab previously. Now we can try to go for the nivolumab at this moment. Yep. Next, we see the adenocarcinoma. So adenocarcinoma, first thing we see second line adenocarcinoma, we need to know that this HER2 positive, is it HER2 positive now? If this patient was previously detected as HER2 positive, next thing we want to make sure is this very important step, which a lot of oncologists or trainees or some surgical MO they will miss out, is they forgot to re-evaluate the persistence of a HER2 positivity. This is very crucial step because we know that tumor cells, they mutate regularly. So sometimes whatever thing we detected last time, let's say HER2 positive previously, at this moment, after one line of treatment, the whole cancer scenario, the whole cancer histology may be changed. They may not be, they may no longer be HER2 positive. Okay. Only we prove that the patient is still positive, then only we'll go for the next line of treatment. Here, for second line, we can go for farm trastuzumab deruxtecan or trastuzumab plus the cytotoxic chemotherapy. If the HER2 is negative, straight we can go for discuss about see what's the patient want. If the patient agree to go for the more intensive treatment, we can go for the ramucirumab plus paclitaxel. If the patient don't want the such an intensive treatment, we can go try for the single agent ramucirumab or taxane or single agent taxane or weekly irinotecan also can. Okay, so at the end, same thing, failure of all these like eventually will lead to best supportive care or trial of pembrolizumab. Or there is another literature drug which is not available in Malaysia at this moment. But then in a foreign country, when you go to because of licensing problem, Malaysia at this moment not available. But if you go to UK or US, you may be seeing that some patient on this drug. Okay, whenever they're on this drug, that means they are towards the last line treatment already. So after we talk about the first two lines of the metastatic condition, is there any new thing in the upper GI cancers that adjuvant setting that we can actually add in by using the TKI or immunotherapy? Yes, there is. But under management of post-operative residual disease after the neoadjuvant treatment surgery for SCC esophagus. Okay. See here, we see patients who have residual disease at resection after neoadjuvant treatment. Here we normally go for SCC esophagus. Our neoadjuvant, well, our preferred way will be cross. That means a chemoradiation, using the cross regime. So after the neoadjuvant therapies and the patient have surgical resection, and if we see that the patient still have a residual tumor from the pathological sample, we can actually talk to the patient to discuss for either we can go for adjuvant nivolumab or at least adjuvant chemo. Here, the adjuvant nivolumab, this is a newly launched, fresh from the oven, is a Checkmate 577 trial, which is using the nivolumab. Here in this trial, 794 patients was recruited, had neoadjuvant chemo radiation, and 71% with the R1 or R2 resection, irrespective of PD-L1 status. Okay, here whenever we want to talk about nivolumab, we don't look at the PD-L1 status. Only pembrolizumab look at the PD-L1 status. Okay, in this trial, esophageal SCC we have 60% and GEJ about 40%. Adenocarcinoma here we have 70% and SCC 30%. So it basically apply for all the upper GI cancers. And by adding in this adjuvant nivolumab, we can see that the median disease-free survival is double from 11 months jump to 22.4 months. This is very significant, and at this moment, the OS data is not mature yet. Okay, so we don't have the OS data yet. So before I end my talk, just a few words to let everyone know about what is cancer immunotherapy. Okay, cancer treatments now is actually undergo a paradigm shift to immunotherapy soon. In other words, means cytotoxic chemotherapy is already a sunset industry. Okay, we try not to use that many of cytotoxic chemotherapy anymore, and we can see that for colon cancer, breast CA, lung cancer, we start to use a lot of immuno or targeted therapy. Okay, and for your information, immunotherapy is currently the only drug that is known as tissue agnostic cancer drug. Okay, a new word that you may learn only from today is what is the meaning of tissue agnostic. Tissue agnostic means like this. I give you an example. Okay, like a HER2 positive drug, HER2 positive cancers we can treat for trastuzumab. This can be seen in the breast cancer, we can be seen in the gastric. But do you actually realize that in other cancers such as colon cancer, pancreatic cancers, brain tumors, they do have HER2 positive. But why trastuzumab never work on this condition? Okay, at this moment, we don't know why. We just know that in those situations, if you use trastuzumab, it will work. Okay, so in what situation that we can say that this is a tissue agnostic cancer drug? That means if you have PD-L1 positive. That's why pembrolizumab is the only drug so far which is labeled by the FDA America as a tissue agnostic drug. That means as long as you have PD-L1 status detected, you will be somehow respond to the immunotherapy. It's just that the more percentage of more higher positivity of the PD-L1 status, the response rate will be higher. That's why they are known as tissue agnostic. That means regardless where you are brain tumors, your breast tumor, your breast cancers, or wherever solid tumors you can be, as long as your tumor histology start to show PD-L1 status is positive, that means towards the end of your selection of the treatment, there must be a role for immunotherapy. This is just a diagram to let you all know that we are actually at this moment. We previously at this moment, now we are at this moment. Okay. This is also a diagram to let everyone know that these are the potential targets that we are actually targeting. Like it may not be actually suitable for all the cancers, like upper GI cancers. They don't have a EGFR. EGFR drug and MET or mTOR inhibitors are not useful here. But this diagram is actually very useful for all the oncology trainees or surgical trainees, because it encounters most of the targeted therapies and targets that involve. Okay, that we are actually trying to work on and in the different solid tumor site. Okay, and that's all for my talk. Thanks. I'll give it back to you, Mr. Han.
Okay. Hi, this is Lau here. So thank you very much, Dr. Teo, for the very insightful summary of the current targeted therapies. So I think we are living in a very, very exciting times where previously gastric cancer used to be a disease where everybody would just give up and say this patient hasn't got long to live. I mean, I myself have seen a lot of my patients in the private side. I can see the private and the government side. When they go on targeted therapies, they actually do get benefit, and some of them even come back after 2 years, which I'm really surprised with metastatic disease. Okay, so
you'll be surprised that they can come back at 4 or 5 years.
Yeah. So before we have to move on from chemo, so or immunotherapy to our next speaker. So the next speaker is Miss T. So Miss T is a consultant upper GI surgeon who practices in the National Cancer Institute. She is a part of our national training committee member as well, and she is also our committee member in our PANSMA. So she's going to give a talk about GIST, especially in the upper gastrointestinal tract. So we move on from cancers to GIST. Okay, so without much further ado, please welcome Ms. T.
A very good evening to all the participants who joined us today for the MUGIS 2021 Virtual Symposium. My name is Tizuchi. I'm a general and upper GI surgeon from Institute Cancer Negara, and I'm going to deliver a topic on GIST in upper GI tract current practice. Today, my outline would include introductions. I believe that the basic of GIST tumor itself is very important to guide us in terms of surgical or targeted therapy. So I'm going to mention a little bit on that. I'm not going to talk in details about the different type of tyrosine kinase inhibitor or different type of surgical techniques. Basically, GIST arises from mesenchymal tissues, and it shows differentiations towards the interstitial cell of Cajal, and it belongs to a sarcoma family. Interstitial cell of Cajal actually lies between the smooth muscle cells along the GI tract wall, and it acts as an electrical pacemaker to transmit signal to the smooth muscle cell along the GI tract. Indeed, upper GI tract is the commonest site for GIST tumor, stomach being the commonest, up to 40 to 60%, and then followed by small bowels. Esophagus is usually quite a rare place for us to get a GIST tumor. Generally, when we do endoscopy, this is what we see. There's a submucous tumor. The mucosa is normal. Typically, it is described as ulcerated or umbilicated lesions. And another photo to show the resected specimen, and you can see that there's an ulcerated area. So therefore, patient can present either asymptomatically that we picked up during a normal scope, or sometimes they can present with GI tract bleeding. When a tumor is way too big, then they may present with the abdominal mass. But under the microscope, it is actually very different. When it first detected by the pathologists in 1940s, they were very impressed with the diversity of the tumor, because sometimes it looks like it looks like schwannoma, sometimes it looks like leiomyoma, and they really think that it is a group of a very heterogeneous tumor. Indeed, GIST morphology did show different type. Some spindle cell type, which is the commoner, and some show a more rounder cell below under the microscope, which is the epithelial type, or you can also have a mixed type of a GIST tumor. But to diagnose GIST, we do not just base on the cell morphology. The immunohistochemistry marker or the panel, it is the most important thing for us to do. In 1998, a group of Japanese scientists in Osaka University, they have detected the mutations of a c-KIT in human GIST tumor. And 94% of GIST had overexpressions of KIT, and they noticed that the other mesenchymal cell like leiomyoma and schwannoma did not express KIT. They also proposed that GIST is originated from interstitial cell of Cajal, because both the tumor and the cell, it's positive for both KIT and CD34. Let us look into the immunohistochemistry panel. So nowadays, we usually diagnose GIST by all these markers. So CD117 and DOG1. CD34 is sometimes used, but it is not as specific as the previous two. So when we look into the timeline, CD34 is the first marker that we detected for diagnosis of GIST, then followed by a specific marker, more specific marker, CD117 and DOG1 later. If we combine the both CD117 and DOG1, we will hardly miss any GIST tumor. Another basic thing that I wish to share with others, it's tyrosine kinase receptor concept, because basically tyrosine kinase receptor, it is a transmembrane receptor which is usually found in GIST tumor, and this receptor generally they transmit or transduce signal to stimulate, to propagate the cell growth, which is the tumor. And the commonest mutation that we see in GIST tumor include KIT and also PDGFR alpha, which stands for platelet-derived growth factor receptor alpha. And for this, all these mutations can involve different exon. The one that I circle generally don't respond to conventional tyrosine kinase inhibitors such as Imatinib. And yes, the growth of GIST is usually stimulated by mutations of commonly by these two gene, which is a KIT gene or the PDGFR alpha gene. But we also see there are up to 15% that there is no KIT or PDGFR gene mutations, which we call a wild type GIST. Why is it important to know the mutation analysis? Is because it will help us to decide which kind of treatment is useful for this kind of certain type of GIST tumor. Because if you have the common mutation type, then yes, your conventional TKI works, whether it is the first line Imatinib or the second line or the third line like Sunitinib or Regorafenib. But it does not apply for other type of a mutation. And therefore, it comes to a concept of Imatinib resistant. Sometimes we do prescribe for patients with Imatinib, but we notice that they don't really respond very well. It is because of these two resistance. Firstly, the primary resistance, which happens in up to about 14% of the tumor, and you can see that it is mainly happening in certain genotypes like KIT mutations, the exon 9 mutations, and therefore in this group of patients, you will need a higher dose of Imatinib. And for the other two, generally Imatinib does not work. So although you prescribe Imatinib for a GIST tumor, which happen to be exhibiting this genotype, you will not see a good response. In fact, you would see tumor progressions. And the second, dairy resistance, it's what we see after a few years of treatment where new kinase mutation emerges, and therefore you see it's as if the Imatinib doesn't work anymore, and you will see tumor progression. The next thing, staging of GIST tumor doesn't really follow TNF staging, but we use prognosticating factors such as the tumor size, tumor site, the mitotic count, or any tumor rupture that we've seen along the treatment. So any size which is more than 5 cm or mitotic count more than 5 mitosis generally give us a higher risk or intermediate risk of a GIST tumor. And of course, the stomach GIST outcome is usually better than a small bowel GIST. When we look at the management, we also look at the size of the GIST. Tumor less than 2 cm, generally it's very low risk, or it is low risk or very low risk. And if we can excise, you excise it. If you want to actively survey it, then you have to follow them up with the scopes and endoscopic ultrasound and excise it if the size is increasing. When a tumor is bigger or more than 2 cm, then we should consider to remove it. The oncological principle is the same. Complete surgical excisions, a clear margin, but a routine lymph node dissection is not a must. When a tumor is way too big, that you expect you cannot, it is borderline resectable, and you cannot, you require a lot of en bloc resections. Then you expect a lot of complications after the resections. Then you should consider neoadjuvant, and before that, you should biopsy the patients, and you give the treatment for 6 months, 12 months maximum, and you reassess them back, and you excise it after that. So after the surgery, if it is a high-risk GIST tumor, then you give them adjuvant chemotherapy. If it's a low or intermediate risk, then you follow them up the first few years, 3 to 6 months, with CT scans. When I prepared this topic, I also look into a few common things that we do when we treat this group of patients. Firstly, it's percutaneous biopsy safe, and secondly, what if the HPE came back and it shows a resection margin involved? Percutaneous biopsy issue always lie at the needle tract seedings, because people will debate whether it would cause further seedlings and later leads to recurrence. Yes, nowadays, nowadays, the biopsy needle generally it's safer because usually there's a sheath in situ to reduce the risk of needle tract seedlings. But is it really safe? When I look into the literature, this is probably one of the biggest study to suggest the safety of percutaneous biopsy in getting a specimens from the GIST tumor. So the conclusion that this author made is it may not increase the risk of GIST recurrence, but we have to be, be a bit more careful, because all of the patients receive adjuvant imatinib after the biopsy. So in our group of patients, you have to understand that in our own Ministry of Health formulary, imatinib is usually indicated for unresectable and metastatic GIST. So if you happen to remove a tumor which you previously biopsy and turn out to be margin clear, you will not get imatinib under the MOH formulary unless the patient wants to pay for it. So the previous study result, you can't really generalize to all the patients where you can't provide adjuvant imatinib. What about the second issues? After surgery, if you have done some white local excisions or white excision and it turned out to be R1 resections, again, generally, if you look into all the literature, it still shows some inconsistent data. The outcome remain unclear, especially for low-risk GIST. And in fact, ESMO guideline did say that the re-excision is not recommended on a routine basis, because generally it does not really associate with worse overall survival. What about for intermediate or higher risk tumor? This recent analysis showed that the overall survival, if you have a R1 resection, it is lower than the R0 resections. But interestingly, if you do not rupture the tumor during your resection, in fact, the R1 resection probably carries the similar oncological outcome as your R0 resection. As I mentioned just now, it's still a lot of inconsistent data. Some data did show that R1 do bad and worse, and some say similar survival. For me, definitely, when you read the literature, R1 resections give you a higher recurrence risk. Although the survival curve may be similar, but it may be because of the wonderful effect of Imatinib. So it does not really change our standard of care of management for these patients. The aim is always aim for R0 resections. So in my current practice, I will still consider re-excisions, but I will first of all, I will look at which margin which is involved. So if the margin involved is from the left arrow, you know that this patient does not need the re-excisions, but if it's on the right arrow, then those are the tumor that I would discuss with the patients to re-excise it, provided it does not cause a significant morbidity. As for advanced diseases, as you can see, this slide, they are full of different mutational analysis, and this is indeed the basis of treating advanced GIST tumor. So as circled, this is the commonest mutations genotype, and the c-KIT, and also the PDGFR receptor alpha mutation. And in this group of patients, we can give a standard TKI such as Imatinib or second line or third line TKI. As for those, we have a slightly different mutational analysis, then different TKI would be offered. For wild type GIST, which is not so common, and you can see that a whole panel of descriptions or different analysis. And if you were to ask me, I do not have a personal experience in dealing with this kind of wild type GIST. Yes. So as a conclusion, GIST tumor, in fact, it used to be a very mysterious tumor because it shows very diversified cellular morphology under the microscope. But we know that nowadays, when we deal with cancer, we do not just look into the different histology. We always look at the immunophenotype and what are the tumor biology. And this is exactly how we should look at GIST tumor, look at the molecular type, look at the genotype, because different mutations will guide you in terms of more personalized medicine. You should give different TKI, different dose of treatment for different type of mutation. TKI looks like, it is a wonderful drugs for treatment of GIST, but nevertheless, I still believe we surgeon plays a very important role in terms of treating GIST. Thank you very much.
Thank you, Mr. T, for the excellent presentation. So we keep and reserve the question to the QA session after the third speaker. We move on to the next topic. Dr. Muhammad Shukri Jahid is a senior consultant upper GI and general surgery at Department of Surgery, National Cancer Institute, Putrajaya. He's a supervisor of upper GI surgery fellowship in Ministry of Health. He's also a president of the PENSMA Executive Committee of PENSA, and also a member of ESPEN, European Society of Clinical Nutrition and Metabolism. And his special interest is in esophagus and gastric cancer and minimal invasive surgery, and as well as nutritional therapy. So Dr. Shukri Jahid will talk about the pre-rehabilitation and enhanced recovery after surgery in upper GI cancer surgery. Over to you, Dr. Shukri.
Thank you, Sudirman, for the kind introduction. Good evening, everyone. First and foremost, I would like to congratulate the MUGIS for the recent election. And now we have the new lineup of executive committee members. And of course, you all have started with a good vibe with this educational platform introducing, a webinar on upper GI cases to all the audience out there. So I'm tasked to actually deliver a topic on prehabilitation in upper GI surgery. With this limited 20 minutes, I try to get everything, the concepts and the pertinent points with regards to prehabilitations within this 20 minutes. So let's start it. Okay, this is the outline of my presentation. I'll be talking on the introduction, concept of rehabilitation versus currently prehabilitation, the current clinical practice guidelines, and the clinical approach towards effective rehabilitation. Now, as we all know, a majority of our upper GI cancers, they are in the group of malnourished elderly patients, and with the background of multiple comorbidities, they are bound to have a lot of problems with regards to their comorbidities and the aging issues. Now, with the this kind of stress, you can see here the recent data from our colleague from the Philippines looking at the cohorts of patients within the hospital, major hospital in Asia countries. And you can see here a lot of these patients who are in the cancer populations, they end up with malnutrition with a prevalence between 40 to almost 95%. And when you look at the clinical consequences of either medical treatment or surgical treatment, they are bound to also have, delayed wound healing, surgical site infection, and commonly pneumonia. Now, when we age, we tend to lose our lean body mass by the 8% from the age of 25 years old towards 40 years old. And from that point onwards, you can see from 70 years old onwards, you can see the loss of lean body mass is about 15%. And this carries a lot of issues with frailty and sarcopenia. And coming on with the issue of upper GI surgery, and we talk about upper GI cancer surgery, either esophagus surgery or gastric surgery. These are very, very stressful surgery. And you can see here the extent of neurohormonal and endocrine response to this sort of surgery, not to withstand the ongoing background of malnutrition and frailty. So end of the day, the patient will end up with more demand with regards to substrates to support the healing process, to support the vital organs, and definitely they will end up with a lot of morbidity or even mortality. Now, in most data, you can see here, surgical outcomes in upper GI surgery is usually very high. It is almost 20 to 40%, and this will definitely disrupt the physical function and the significant deterioration in the patient's quality of life. And we haven't talked about the adjuvant therapy of where the patients are going to be treated further. And if we will be able to actually monitor the patient's lean body mass, anything that is less or more than 20% of lean body mass loss, this is a very, very crucial and critical point where beyond this 20%, then the body would have very difficult to actually adjust whether they would actually, the proteins or the substrate would actually support wound healing or to support the vital organs and the preservations of lean body mass. So this is a very crucial thing that nowadays that it is not only weight that will determine whether the patients would undergo major surgery, adjuvant therapy in a successful and very good response, but it is the lean body mass that is the most important thing. And we have to also remember that in this era where we have a lot of patients that is a problem with obesity as well as overweight. Weight is just not the lean body mass, that is also include the fat mass. Now, as you all know, enhanced recovery after surgery was mooted, more than 20 years ago. It was actually highlighted to actually to take in several factors with regards to patient recovery. And when all these factors and all the protocols in managing patient perioperatively, if it can be done in the care bundle manner, you can end up with good outcome, whether it is shortened hospital stay, less morbidities, even mortality. And as you can see here from this diagram, in the past, it is always that rehabilitation is concentrated on the post-operative period, and it was never discussed or never been addressed for those patients who come in within such sarcopenic, cachexic, and frail condition. So this is the very most important part where prehabilitation starts to come in and help the patients. Now, in the traditional way, we usually refer our cases to the pre-anesthetic clinic to assess them with regards to their comorbidities, and we try to optimize their comorbidities. Of course, if the patient is a chronic smoker, at least 14 days of cessation of smoking is very important because the respiratory function, especially if it involves thoracic surgery, these are very, very important. And of course, as you all know, enhanced recovery after surgery has several, categories from the preoperative, intraoperative, as well as post-operative components, which we have to follow. And if we are to follow properly, then the patient is expected to recover with minimal functional deterioration. But as I mentioned earlier on, it was the prehabilitation that was not discussed or addressed. It was only rehabilitation after the surgery. And in ERAS components, if you can see, they have already started to modulate intraoperative stress by giving the patient a complex carbohydrate carbo drink. This is to actually modulate the stress factor during the surgery, whereby you can attenuate the insulin resistance during the stressful moment of the surgery. And in the post-operative period, it enhances and it encourages the immediate post-operative recovery by the introduction of early feeding, which was something that is not a common thing in the past because we tend to fast our patient for 7 days and we put the patients on only plain breaks. And of course, after doing ERAS in the past 20 years, we still see complication, especially the respiratory complication, affecting about 25 to 55% in elective major abdominal surgery. And this is where prehabilitation starts to come in, and people were talking about how well and how far more they can optimize the patients and what are the components of prehabilitation that we should be talking on. And if you look at the ISPEN and the ASPEN guidelines, which I will share with you later on, if these patients, they are at high risk or they have multiple comorbidities or malnutrition from the very beginning, when you see your patient or assess your patient in the clinic, they should have a delay in their elective surgery for at least 14 days for proper prehabilitation. And in the recent guideline also, they have actually shown that immunonutrition in major upper GI surgery is highly recommended, which I will discuss further later on. Okay. Now, as we have mentioned before, majority of this cohort in upper GI cancer cases, they are elderly, they have reduced physical functions, and they have reduced mobility. And this physical deconditioning is actually a bad component or a bad factors towards withstanding any kind of stress during the surgery or the very stressful moment after the surgery when the body needs to support the healing process. And therefore, we have to do something with regards to this body or physical deconditioning, and we have to combine both nutrition, which is, we all know that is the most important component in enhanced recovery after surgery, with physical conditioning. And therefore, the audit has actually now concentrated more on overall survival, because early data have shown that if the patient will be to be discharged from the ward after major abdominal surgery with good nutritional status and good functional status, they tend to have better overall survival comparable to their colleagues within the same staging, if it is a cancer cases, or within the same severity of surgery. Now, if you can see here, these are the concept of prehabilitation wherever the patient is admitted due to upper GI cancer or any other cancer for that matter, that they would definitely have a very much affected functional capacity. And with prehabilitation, we started off with early nutritional therapy, early exercise or physical conditioning. We can actually improve their functional capacity even before the start of the surgery. And because you can see here the stress of the surgery, and definitely after the patient undergone the surgery, they will definitely have another component of very stressful medical therapy, that is the oncological therapy. We will expect the patient to have a shorter recovery, a better functional capacity, a well-maintained reserve with regards to the cardiac reserve, respiratory reserve, liver, kidney, as well as the lean body mass to actually face the stress of the adjuvant therapy. So, in general, prehabilitation is just a process of providing patients to have a better reserve with regards to their lean body mass as well as their vital capacity to withstand the stress of surgery. Now, of course, like in any other major surgery, we have to assess our patient with regards to their history, especially the appetite, the impact of the disease with regards to the nutritional status, especially when you all know upper GI cancer, they affect the first passage to the enteral nutrition or the oral nutrition, and definitely malnutrition will set in very fast. And with regards to the laboratory examination, it is very important that those patients who are severely malnourished at high risk of developing in-hospital malnutrition, we have to screen for refeeding syndrome, because sometimes all the good nutrition and all the good improvement with regards to the prehabilitation will not kick effect if you do not correct their refeeding syndrome. So refeeding syndrome is basically when the patient in severe depletions, we started off with high glucose or a very high calorie intake when the patient is in a severe depletion, and they will have symptoms of that is resulting from hypomagnesemia, hypophosphatemia, and hypokalemia. And sometimes these symptoms, they are very subtle, and they are just not responding to your prehabilitation. And of course, it is very important anthropometric measurement. As I mentioned earlier on, nowadays, we are not just looking at the weight loss or even the weight. We are looking at the lean body mass, because these are the most important thing to actually support the patient throughout their therapy. And of course, if you are managing cancer patient with the repeated CT scan before and after neoadjuvant therapy, or even during the initial assessment or staging of the cancer, you can actually assess or predict the amount of skeletal lean skeletal muscle index that the patient is having. And of course, if you have your dietetic services within your institution or hospital, you can use bioimpedance analysis to actually look at the lean body mass and even the fat mass and the deterioration of improvement after your prehabilitation. And of course, the functional status need to be assessed. And if you were to actually put up any kind of prehabilitation program, the assessment has to be include pre and post prehabilitation, and you would like to see whether the patient is actually improving or not. So this can be in several forms of assessment, either the usual performance status Iko-Okanovsky's, or the 6-minute walk test, the short physical performance battery, and definitely nowadays it is much easier by just using the hand grip dynamometry, because in several studies it has been shown that it is equivalent to show the leg extension strength as well. Now, coming back to the guidelines, if you can see the previous ISPN guideline in clinical nutrition in surgery have actually highlighted those patients who are at high risk of developing malnutrition, those are having weight loss of more than 10%, BMI less than 18.5, if you were to do any kind of nutritional screening, SGA grade C or NRS more than 5, or preoperative serum albumin less than 30 gram per liter. And they highly recommend that this sort of patient should have 10 to 14 days of multimodal prehabilitation, which include not only nutritional, but also physical exercise component. And this is a very important landmark study, which just show how 14 days of nutritional prehabilitation can actually improve the overall outcome with regard to surgical site infection compared to those patients who does not have any kind of intervention and undergoing gastric surgery. This is the latest guideline of ISPEN with regards to clinical nutrition in surgery. The one that I've shown later, the one that I showed just now was 2017. This is the upgraded one. It has better illustration with regards to the components of rehabilitations before surgery, after surgery, and after the recovery. So you can see here, coming on from your screening for malnutrition, you can categorize your patient whether they are high risk or low risk, and whether they have good nutritional intake. If not, usually we would actually recommend enteral nutrition or supplemented with parenteral nutrition, depending on whether they can actually tolerate enteral nutrition. And definitely to postpone the surgery at least 7 to 14 days. And when we talk about cancer surgery, sometimes you cannot just, you just can't beat cancer cachexia. That's why 14 days is the maximal limit for us to actually rehabilitate the patient, following which, depending on the assessment, you may want to actually counsel your patient that if they do not respond well, that means they are not fit for the major stressful surgery. And of course, I have touched a little bit on immunonutrition before, and it is highly recommended in the latest 2021 guidelines that immunonutrition is very, very helpful, especially in gastrointestinal surgery, and its role in improving the lean body mass I will discuss further on later. Now, hand in hand, if you look at the ASPEN guideline in clinical nutrition in surgery and clinical nutrition in cancer, they are almost in tandem with regards to the nutritional intervention and exercise. Okay, and sometimes we also do prehabilitation for those patients who are undergoing or about to go new adjuvant therapy, or we may take in back our patient for prehabilitation before they are going on for adjuvant therapy. So this is very, very important, and I actually would like to implore everyone to actually look at this new guideline, which is just fresh from the oven. Now, coming back to the exercise, even in clinical nutrition for cancer patients, they recommend physical exercise, and specifically, they have actually mentioned here, it is not only aerobic exercise, but resistant exercise, because these would actually improve the strength and the muscle mass. And with regards to pharmacological nutrient or the immunonutrient, you can see for those patients who are undergoing medical medical therapy, medical oncology therapy, they highly recommend the use of omega-3 fatty acids containing in the enteral formula to actually improve the lean body mass. Now, for surgery, it is highly recommended that all patients that is undergoing curative or even palliative surgery should be managed under the program of ERAS. And especially so for upper GI, the use of immunonutrition is highly recommended. So now, let us look at how best can we actually implement all these guidelines. Now, these are the recommendations that we have so far with regards to the nutritional therapy. I will talk about the nutritional therapy first, then we will talk about the physical rehabilitation or prehabilitation. Now, for those patients who are very frail, severely malnourished at the very first, assessment, definitely their physical reserve has been very much impacted by the disease. you have to start very low, 20 to 25, perhaps even less, especially if the patient is down with refeeding syndrome. Once the patient improves with your nutrition therapy, with the initial physical exercises, then you can increase up to 25 to 30 cal per kg per day. And with regards to the carbohydrates and lipid, you have to remember it has to always be dual energy provider. At no time that the patient should be only fed with carbohydrates only. So that's the reason why we will encourage for those patients who are undergoing major cancer surgery to actually just take on the enteral nutrition, which is better, well-balanced with all the vitamins and trace elements in this dose recommended intake. So that is better for the well-being and of course to improve the functional as well as the lean body mass for the patient. And protein, which is very important, at least we have to take, they have to take 1.3 gram per kg per day. And this has to be high quality protein containing leucine with the HMB, and it has to be equal distribution between their meal, either in the breakfast, lunch, as well as dinner. And that's the reason why if you were to give the patient regimented enteral nutrition, say 3 hourly or 4 hourly in the day, then the patient will get the best benefit from the good protein provision within this nutritional therapy. And of course, do not forget when it comes to vitamins and trace element, it is not much an issue when you are providing the patient with enteral nutrition because all the vitamins and trace element is already infused within the formula in the DRI. But the problem is always when the patient cannot take anything per oral, or if you have a very structured esophageal cancer that you cannot pass the enteral tube down to the stomach or beyond, then the patient would definitely need parenteral nutrition. And this is where you need to have supplementation with vitamins and trace element. And do not forget, you need to actually provide the patient at least for a week with vitamin B1 or thiamine, especially those patients who are at risk of refeeding syndrome. And of course, I have mentioned again and again the importance of enteral nutrition rather than normal diet, because if you were to actually prehab your patient at home, you think that the patient is well with good weight. We do not know how much good proteins and carbohydrates that they're actually taking at home and whether they are getting good nutrition with regards to the vitamins and trace elements. So it is just better to actually prescribe them with enteral nutrition. Now, when it comes to the improvement in the lean body mass and functional reserve, nutrition plays a very important role when it comes to this improvement in lean body mass and functional status. And for that matter, I think I have mentioned earlier on that you have to give your patient at least 1.3 gram of good protein in a day, equally distributed. And now we would like to touch on how immunonutrition can actually help to enhance protein synthesis and further improve the lean body mass. Now, omega-3 is part of the polyunsaturated fatty acids, especially it has very important components of the eicosapentaenoic acid as well as docosahexaenoic acid, which is very important as pro-inflammatory markers within the body. And as we all know, when the patient is down with cancer, there's a lot of inflammatory cytokines as well as nuclear factor kappa B as well as the tumor factors that is playing around, that is causing a lot of insulin resistance, a lot of substrate mobilization from the fat as well as the lean body mass. And this will actually interrupt with regards to the preservation of the lean body mass. With provision of enteral formula or parenteral formula that is enriched with omega-3, they are high in content with TP and DHA. These are anti-inflammatory. They will improve the muscle mass, and therefore you can get the manifestation of improved muscle strength as well as physical performance. Now, there are several ways of how this can play a role with regards to within nutrition as well and physical improvement. And of course, I mentioned just now, the high quality protein, leucine has to be infused within the good high quality protein, because this play an important role in the mTOR1 mechanism of protein synthesis. With EPA and DHA enrichment through your enteral formula that is enriched with omega-3, it can block all the negative inflammatory markers from the cancers, inflammation, or even infection. With reduced inflammation, you can reduce insulin resistance. Once you reduce insulin resistance, then you can enhance protein synthesis. And of course, the EPA and DHA also involved in a lot of cell buffer, especially resolving, protecting, and messerins, and this would further reduce the inflammation. And this is how omega-3 can actually help the protein synthesis. Now, frailty and cancer are associated with lack of physical activity because once the patient are sick, they tend to lie down in the bed. And with sedentary behavior, the patient will further lose their lean body mass, reduce physical function, and they will have higher possibility of developing insulin resistance. Now, when we start to introduce exercise, what exercise can actually help is that they can counteract functional decline, enhance patient performance, attenuate sarcopenia, and limit the deconditioning associated with disease burden or even the aging process. Now, as we all know that respiratory complications are one of the commonest and the most prevalent complication when it comes to upper GI surgery. These are related to a lot of factors, especially the anesthesia that is involved, especially when you have thoracic surgery, the incision, whether especially open surgery, surgical technique, and of course the pain management. All in all, you will have a total pulmonary capacity and volume decrease and lack of lung inflammation. So basically, when the patient recover from surgery, if they do not have good functional reserve, especially the respiratory muscles are all very much attenuated, they will have shallow monotonous breathing without this periodic sighs. And usually we sigh because we need extra oxygens. And definitely if you were to have patients who always lie in bed 24 hours after the surgery, the diaphragmatic muscle will become dysfunctional. Now, this is just become even worse when the patient continue on to have a recumbent position in the bed, and they will have definitely impact mucociliary clearance, and respiratory function will definitely be affected. This is when respiratory muscle conditioning is very important when we subscribe or when we prescribe the inspiratory exercise to our patient. It can either be inspiratory muscle training or expiratory muscle training. I believe all of us are very familiar with these two important gadget or device, respiratory device that we have. They can either be from the flowmetry or the volume derived device, which can actually enhance the respiratory muscle as well as the accessory muscle and the diaphragmatic muscle. Now, these are the very effective rehabilitation when it comes to respiratory muscle function. We tend to we like to ask our patient to actually do this repeatedly in a day. And if possible, you can see here, it has to be in tandem from one exercise to another. So there are basically 4 component exercise: deep inhalation, which will improve the respiratory and accessory muscle, assisted by the upper limb extension. And we always tell our patient to hold their breath for a few seconds. And this will be followed by forceful expirations. And all in all, you have to do 10 times of the inhalation, followed by 10 times of the expiration, followed by 10 times of incentive spirometry, either the tribal flow meter device that you see just now or the volume device that you have seen just now. And of course, last but not least, you have to tell your patient to do coughing, a very forceful cough, because this will help to improve the diaphragmatic muscle function, especially if they were to undergo major upper GI surgery. So if these to be repeated several times in a day, several days in a week before the major surgery, you can improve the transpulmonary pressure, you can improve the inspiratory volumes, you can re-establish the normal pattern of pulmonary hyperinflation as if that you are sighing, getting more oxygen. Okay, so this will help the patient to improve better. Now, the emphasis with regards to the exercise, we have touched a little bit just now that exercise is not only aerobic exercise, but also you have to include some kind of resistant exercise. Here, I'll just like to show you what we normally prescribe to our patient. This is the exercise machine, or the cross trainer we call it. This actually gives the patient the ability to increase the aerobic functions as well as the muscle resistance that work on very well on the body, the core body, the upper limb, as well as the lower limb. And of course, if you to do this in combination with the good nutrition, you can see here the patient is having his enteral tube, good nutrition with all the physical prehabilitation, the patient would be well prepared for this stressful high-risk major surgery. So ladies and gentlemen, in conclusion, prehabilitation is a crucial step to prepare a high-risk patient for high-risk surgery. Prehabilitation provides not only nutritional, but also functional reserve to withstand the stress of major surgery. ERAS, as we all know, is the way forward. But in the previous effort, they were only concentrated in preoperative nutrition and postoperative rehabilitation. Therefore, a combined nutrition with not only the calories, but also protein goals, as well as the functional goals with good physical rehabilitation will ensure that the patient has an improved overall clinical outcome. With that, I thank you, and I would like to welcome any questions from the audience. Thank you very much.
Thank you, Dr. Shukri, for the comprehensive talk. Now we open session for Q&A.
Perhaps I could start. So, Dr. Teo, with regards to the concept of trastuzumab affecting the ejection fraction, so what is your lowest threshold, and how do you go about managing the risk if the patient is willing to take it?
Okay, regarding the ejection fraction, theoretically, the guideline never say that there's a minimum EF value. Okay, but they guided from the guideline, they actually tell us that we need to monitor as long as patient is asymptomatic at the stationary condition, and then we monitor the EF, and if that particular EF value drop more than 10%, then that's a time for you to off. It can be at the EF of 40 plus, it can be EF of 60 plus or 70 plus. So the cutoff point is 10%. But in our local setting, due to restriction of resources, some government hospitals, they tend to use age together with a minimal reasonable EF, let's say like 55 with the age of 60 or something of the age of 55, like that. Certain hospitals, they practice that for them to prescribe trastuzumab. Yeah, but in the international guidelines, we never actually use it. We never use a particular numbers to say that is a cutoff point. We use that as a guide for us to know that when should we stop. So obviously, if the EF baseline is about 40 something, so the margin for it to drop is very is just about 3 to 4 ejection fraction, right? So usually it's not advisable at that moment. Yeah. Because two doses itself, we know that somehow for a young, healthy, and fit patient, the ejection fraction sometimes may still drop about 2 to 5%. It is expected. Yep. So there's not an absolute value to say how much you actually cannot go for trastuzumab.
Yeah, Theo, usually for when we send the specimen to pathologists, we don't routinely ask for this HER2 study, not like breast surgeon, automatically they ask for ER, PR, HER2.
That is under government setting. Government setting. Okay, that's because government, they do have a special fund just to support the breast cancer. Yeah. Last few years, there was a discussion talking about want to add in this for the gastric cancers or not. But unfortunately, the pathologists think that the gastric cancers, right, the percentage of the gastric cancer to come with the HER2 positive, right, is actually 15% and below. So they don't think it's cost effective. But in private practice, ideally we should check the HER2 status, especially if it's adenocarcinoma.
All right. That's why
Yeah.
my
And on top of that, since we are checking for HER2, now usually I would talk to patient about checking the MSI, all those things together, one shot.
okay. All right. Thank you.
Theo, the 15% number, where do you get it from actually?
Is actually an international consensus. Certain continent may be 10 to 15.
Are you aware that there was a local publication, I think from Subang Jaya, they look at the local HER2 yes, our Malaysian. That's why at one point I was 5%. Is that
Then
was
if it's 25%, third. Breast is
I
just for 1/3.
cannot remember that paper. Is it purely on breast, or I have to go and search it up again?
Because the time the pathologists use this as a reason, not to support the this thing. Yeah. And another thing is that another reason why in government practice they don't routinely check is because the government oncological service, they don't actually prepare a special fund for trastuzumab in the gastric cancer. Yeah, that is the reason. That is one of the main reasons also. So there's no point that they check for something and then there's no treatment for that.
Yes, correct.
So
Dr.
going on
sorry,
to, sorry.
Yeah, Dr. Teo, would you also consider the effectiveness of trastuzumab for HER2 gastric cancer as adjuvant therapy? Or I mean, because when you look at the HER2 for breast and gastric cancer, to gastric cancer usually is very heterogeneous, and therefore even if it's positive, the effectiveness of trastuzumab is probably up to about only 50%. So whether it is really useful to prescribe such expensive drugs for 50% effectiveness, probably that is also something that we need to consider if we really want to make it a routine check for gastric cancer.
We can think of actually when the trastuzumab started to become adjuvant in the breast, right? People started to think about this in the gastric cancers, but unfortunately, in the international papers, right, there were not many papers can actually prove that there is a significant benefit of adding the trastuzumab in the adjuvant setting. Not many, and even though some papers may show some benefit, and then unfortunately those data cannot be reproduced in most of the centers. That's why it is not widely available. That's why just now I remember when in my presentation I did mention about a tissue agnostic drug, right? HER2 is one of the common examples that we use to describe why they are not tissue agnostic drug, because not all the cells with the HER2 they will somehow respond to the trastuzumab. Whereas pembrolizumab is a tissue agnostic drug. That means, and then whenever this tissue possess the PD-L1 positive, right, they will respond to the immunotherapy. It's just that the responsiveness may be vary. If the positive is very high, like CPS 9 or and above, then the response is very great. Yeah, somehow they will have some response.
There's a question from participant for Mr. T. Number one is, may GIST become a cancerous? And number two, what is the recommended strategy for recurrent GIST? Imatinib first or surgery first if resectable?
I let Ms. T's answer first. Yeah, that's her territory. I can supplement later.
Okay, thanks, Dr. Teo. Jenny, I think GIST tumor nowadays, we should regard it as cancer. In 2020, the WHO pathology classification has already stated clearly that irregardless of the size and the mitotic rate of a GIST tumor, it is considered as malignant. So you shouldn't see pathology reporting as GIST being a benign GIST anymore, because this is according to the latest WHO pathology classification. So it is a cancer. And for the second questions, it is the recurrence. I think if it is a recurrent after the first complete resections, that means it's the R0 resections, then you should regard it as a metastatic disease. But if it's R1 resections for a recurrence and it is resectable, then I probably consider to resect it first before offering the patients adjuvant. But if it's really a recurrence after the R0 resections, and since we consider it as a metastatic disease, you have to be a bit careful in whether you want to resect first or offer the patients Imatinib. I think my approach would be to discuss with oncologists to offer the patients Imatinib first, because local, if we use MOH formulary, if the margin is clear after the surgery, the patient, it's not going to get the adjuvant chemotherapy, because this group of patients belongs to a high risk group and they will benefit from Imatinib. So by giving them a course of before surgery Imatinib, then you know that whether if the disease progress further or if you can control the disease by doing a surgery later on. That would be my opinion. If Dr. Teo wants to add anything, or even Mr. Shukri.
Just a few words. GIST is theoretically is a sarcoma. So no doubt that it is a cancer. It is under the soft tissue sarcoma category. Okay. Then for the, I do agree with the Misty that we should go for the Imatinib first, then followed by the surgery. But then there comes another question, Misty. If the Imatinib is so fantastic and so wonderful, right? Initially we plan to neoadjuvant, and then later when this mass becomes so significantly improved, do we still proceed with the surgery? That become a big question, because when the mass no longer cause any local compressive symptoms, but let's say it is still significantly large, let's say like a 5 to 8 cm, but then no longer cause any local symptoms, right? Do we still proceed? Yeah, that will become a more questionable thing.
For us, if we look at the risk of secondary resistance for such patients, because I think some study did show that up to about 50% of them, because so if the patients still remain, that means the disease did not progress and it remained resectable, I will probably discuss with the patients and do the surgery for them to remove the tumor to avoid the risk of a secondary resistance in continuing treatment for this group of patients. That would be my approach.
Yeah, because I do have a few patients previously, right? We after some a period of treatment, patient refused for surgery already because they think they're okay already. Yeah.
I mean, that happens with the cross also. You see, a lot of patients, they cannot eat after the cross, they can eat. Then you do a scope, it's like complete clinical response, they disappear. Then they turn up after 1-2 years, tumor everywhere.
Oh, that one different. For cross, right, I will tell them from day one itself, tell them this is not to replace the surgery. They must agree with this first, then only we start. But for the Misty story, it's different. That one is for locally advanced and non-resectable initially, then we make it resectable. That one is different. This is cross itself is a curative intention.
Okay, non-resectable. Okay.
So usually for this kind of case, we will tell them in advance and say that you want to start this thing, you must agree with this. You cannot last minute and say that, oh, I feel that I'm better, then I don't want to go for surgery. Then the whole thing become very inferior. The outcome will become very awful later. Yeah.
They will somehow disappear.
Yeah. So need to keep brainwash them.
Perhaps now you should ask Mr. Shukri one of the questions. So one of the participants asked Mr. Shukri with regards to immunonutrition. Is it safe to be used in immunocompromised patients or those that are apparently recovering from septicemia?
Well, when we talk about nutrition therapy, I'm not suggesting nutrition support. Okay, this is nutrition therapy for those patients who are recovering for any kind of insult, be it infection, cancer, or any kind of medical or surgical therapy. We have to actually support the recovery of the muscle, especially the muscles of the vital organs. Now, when it comes to immunocompromised patients, we have to look at whether they are stable with regards to their oxygenation, perfusions, and most importantly, whether the gut is functioning or not. And especially, we all know that immunocompromised patients, they are down with a lot of mucositis, and the issue of nutrition absorption along the small bowel is very much affected. So this is the most important thing that you have to actually take note, whether the patient will actually tolerate enteral formula. If otherwise, if the patient is stable, they do not have issues with gut tolerance, and of course, we can start off with immunonutrition. And when we talk about immunonutrition, is any formula that contains either the arginine in combination or singularly, arginine, ribonucleotide, the omega-3, or even any one of the antioxidant. Yes, of course, as long as the patient is stable, they can tolerate orally, as well as gut intolerance is not an issue, you can start immunonutrition.
Thank you, Mr. Shukri. Just out of curiosity, another question for you. Do you have a specific standardized preoperative exercise regime for your ambulatory and non-ambulatory patients?
All right. I think generally, when we talk about exercise, rehabilitation, or even rehabilitation after surgery, we have to actually discuss the objective, okay, with whoever is the provider of the physical exercise within our institution. And usually in the MOH institution is always the physiotherapy department. So I can see a lot of us do not have this good interaction, or we don't normally communicate well with our physiotherapy. So actually they have a very good system of how they can actually help with regards to rehabilitation in our chronic ill, bedridden, frail patient, or even elderly patients. So if the patient is very much dependent and very much into, resting, and most of the time they are in the bed, we always started off with a resistant exercise, because the simplest resistant exercise will actually help build muscle with good nutrition therapy. Now, I'm sure all our physiotherapy department all over Malaysia, when it comes to Ministry of Health hospital, they come equipped with this resistant band. And this resistant band, it comes in different colors, which indicate the different resistance. So you can start off with the upper limb, lower limb. You can also work on the core body muscle. So you can start this even though the patient is actually bedridden. Once you can see improvement, but the thing is that usually it has to be continued on for several times in a day, even though the patient in bed, because you can see our physiotherapists, they can only spend 10 to 15 minutes for one patient, because they have the whole hospital to cover. So it goes back to the primary team to actually continue on with supervising the patient with regards to this physical resistant exercise. Once they have shown an improvement with the targeted objective, you can start on with the rest of the combined aerobic and resistant exercise. So coming back to this aerobic and resistant exercise, one, they are able to walk, they are ambulatory, you can send them down to the physiotherapy department. Definitely all physiotherapy department are well equipped with at least one combine aerobic and resistant exercise. For example, they have treadmill. If you have elderly patients who have issues with osteoarthritis, knee pain, spine, back pain, they can't do this. They also have at least the static cycling exercise. The thing is that when you do this cycling exercise, static cycling exercise, or even the treadmill or the cross trainer, which I've shown just now, it has to be targeted every day. The resistance has to be increased. The inclination of the treadmill has to be increased. Then only you can see the impact of both aerobic as well as the resistance will come in. So coming back to the question, you have to look at what can be offered by your physiotherapist colleague, and just go down and look at the equipment that they have there, and start with good communications and program for all your chronic and ill patients.
Maybe last question from the participant, I'm not sure, maybe from neighbor country, Indonesia. What's option treatment for synchronous liver metastasis related gastric GIST? Maybe for Mr. T.
Yeah, I think for liver GIST with liver mets, generally there's no recommendations for liver targeted therapy, including resections, yet at the moment. So I would say that there's no uniform treatment for it, because liver being one of the commonest site for mets in GIST tumor, the second one would be either the omentum or the peritoneum. I think this one we should regard it as a systemic disease. TKI would help, but there are some reports to show that, either you treat the liver separately by any liver targeted therapy, RFA or whatever it is, but there is no uniform recommendations, and there is no improve in survival by treating the liver itself. So the current treatment, it is still a systemic TKI, which is the practice nowadays. Yeah. Dr. Teo, you have anything to add on?
No, I have nothing to add. Thanks.
So with that, we've pretty much covered everything, is it? Any last comments from anyone?
Yeah.
I think there's a question here. What type of nutrition solution that contain good amount of protein and immunotherapy? Now, of course, our market is flooded with a lot of, so-called nutrition supplementation. But my professional advice to all my colleagues, surgeons, physicians, or whoever that is practicing medicine is that try to prescribe the scientific base formula that is backed up with scientific evidence. Okay, of course, we would like to know what are the content, and for all types of solution, it has to be a balanced nutrition. That means you cannot just give immunonutrition, but at the same time you disregard the provision of calories and protein. So it has to be a balanced nutrition. That means it has to contain macronutrients, carbohydrate, fat, and protein within the recommended percentage, as well as the micronutrients, which is all the important vitamins and trace element, also in the dose recommended intake as recommended by FDA. And with that, you can add on certain, you can choose a certain product which has add-on value. That means they have balanced diet, they have balanced formula, but they have added supplement. For example, added omega-3 fish oil, added antioxidant, nucleotide, or even arginine. So any formula that is good, because I'm not going to tell you, because I won't indicate any kind of industry with regards to this entero formula, but any formula that is shown by, that is proven well with scientific evidence is good enough for all our patients.
That's a very valid point. First and foremost, I think I'd like to thank everyone for coming on today. Topics were very good, well presented. I think everyone benefited. Thank you, Mr. Shukri. Thank you, Dr. Teo. Thank you, Ms. T. Job well done. Thank you to my fellow panelists. For those of you who've been with us till the end, I'd like to thank you all for participating and asking all the nice questions. We really like participation. We also should thank the industry sponsors, because without them, it's very hard to organize educational activities on this scale. We've got, again, more than 200 participants consistently per session. I'd like to invite you to our next week's event as well, which is about upper GI training, comparing East versus West. Some of our trainees who have returned would give us some feedback, and also managing complications. So without pretty much that, I'd like to thank you all for being with us till the end, and have a good week. See you all next week. Take care.